thank you for the opportunity to present the National Adult Cardiac Surgery audit results from the last 3 years. First, I'm just going to go through some of the demographics of the patients that have been, the operations that have been performed. And although the data for most of the report is for the last 3 years, I've got some data from a longer time period to show the trends. And this is all operations performed in heart operations performed in the UK, and you can see for the last 6 years there's been a gradual fall from around 35,500 6 years ago to around 31,000 now, which represents a 13% drop in the number of operations being performed. This is now looking at the number of operations performed by both age and sex. The scales on these two graphs are different, and roughly 2/3 of the operations being performed are on male patients and 1/3 are being performed on female patients. And these are the trends according to age over the last 6 years. And there's been little change in the male patients of over 70. There's very slight reductions in the patients who are under 60 and between 60 and 70. Whereas this is quite different once you look at the female patients. They also have little change in the patients who are under 60 and between 60 and 70. There's been quite a marked drop in the number of women over the age of 70 having surgery in the last 6 years. And this corresponds to a 23% drop. There was a suspicion this may be due to increased numbers of TAVI procedures, but when we've looked at the data, this would not explain the difference that have been seen. This graph now looks at the mortality of all operations being performed, and this goes back over 10 years. And despite the complexity and the risk factors going up over the time period, the mortality that's been seen in the UK has been gradually dropping from about 3.3% 10 years ago to about 2.3% now. However, for the first time in the final year of the audit, there has been a slight uptick. We're not sure whether this is due to a gradual plateauing over the last 3 or 4 years, or whether we're going to continue to see this trend. We're going to have to watch this carefully over the coming years. This is the outcome monitoring that we do of every hospital in the UK. We look at the aggregate mortality of the units over the last 3 years, and this is up until the end of March 2020. And the good news story from this is if the hospital has a black dot, this is a forest plot surrounding the UK mean survival here, and if they have a black dot, their survival is as expected. And every hospital in the UK over the last 3 years has had as expected mortality rates. The one exception is this green dot here, where the hospital has above expected survival rates. There are no red outliers. Moving on, looking at specific operation types, as we showed on the earlier slide, the numbers of operations have been falling, and this is also seen with the number of coronary artery bypass operations have been falling over the last 6 years. And this is almost entirely explained by a drop in the elective coronary operations, whereas the urgent and the emergency operations have stayed largely the same. This looks at the mortality of the coronary artery surgery in the UK, depending on whether you have the operations performed urgently or electively. And we have fantastic results. In the last year, elective coronary artery surgery had a 0.6% mortality. If you have your operation performed urgently, where you've come in usually in the last week with a heart attack and get kept in, to have your operation, the mortality is around 1.1%. This chart looks at the numbers of aortic valve procedures overall, includes both surgery and TAVI procedures. And over the last 6 years, there's been around a 25% increase in the number of procedures, largely for people with aortic stenosis, which is a good news story. We're just beginning to see a drop-off in the number of surgical procedures in the last year or so, as the aortic valve numbers have been falling slightly. There's been a larger drop, however, in the number of patients having combined aortic valve replacements and coronary artery surgery of around 30 to 40% over the last 5 to 6 years. The most noticeable thing, however, is that TAVI for the first time last year overtook the numbers of isolated aortic valve replacements, and this reflects the trends that have been seen in the USA and Germany. So moving on to some of the QI measures, there's several more than I'm about to present within the report, but these are just some of them. So the first one is waiting time for elective coronary artery surgery. And as the UK as a whole, the waiting time has gone from 97 days in 2017 to 104 days in 2019-20. And the increasing waiting times for elective surgery is seen across all four of the units. Sorry, all four of the UK nations. This is looking at the same data by hospital. We set a target that the elective surgery should be performed within 12 weeks of a coronary angiogram, as this represents 2/3 of the 18-week referral to treatment time. And as you can see, there are 8 hospitals that meet this target, and the hospitals to the right of the red bar here do not meet the target. This is patients having urgent CABG. As I said earlier, urgent CABG are those performed during the same admission. Usually it's the same admissions you've come in with a heart attack. And unfortunately, the proportion being performed within 7 days has been gradually falling. The best performance is in England, but even so, the performance has got worse over the last 3 years. And this looks at the same data by hospital. The target within the report is that 75% of all coronary operations should be performed urgently within 7 days of their diagnostic angiogram, and there isn't a single hospital in the UK that meets that target. The best hospital achieves it in 60%. This metric was introduced a couple of years ago, as it's contained within the GIRF report from 2018. The recommendation is that an elective patient should be admitted on the day of the surgery. The reason for this is it saves a day in hospital, so there are cost savings, but more importantly, it's also a quality measure, as patients coming in are less likely to be cancelled as they have to come to a pre-admission clinic. The comorbidity can be picked up and assessed, and things like low hemoglobin can be treated. And it also usually requires the patient to be seen by a consultant anaesthetist prior to the day. So again, all the different issues can be picked up in advance. And since it was recommended by GIRF, you can see that the rate in England has risen from around 10% to just over 20% over the last 3 years. The take-up in the other 3 nations, however, has been quite small. The target within our report is that more than 50% of elective admissions should be on the day of surgery, and 4 hospitals meet this target, and the 2 best hospitals managed to achieve it in over 70% of all their elective admissions. And then the final metric that I was going to show, mitral valve repair has long been considered the gold standard for patients undergoing isolated mitral valve surgery. In an ideal world, we would measure mitral valve repair rates purely in degenerative disease, but because of coding within the database, we've chosen to do it purely as a proportion of all isolated mitral valve operations. When you measure this across the UK, it's slightly worrying to see that the repair rate has been falling from about 65% to around 61% over the last 6 years. And there's a huge variation between units. The best unit achieving around 91% repair rates, and the worst unit in the UK only manages to achieves 22%. So finally, what does the future hold for the cardiac surgical audit? I think, as you can see from the measures we've been presenting, we're moving far more towards looking at several QI measures, and within the report now there are at least 11 QI measures that we're measuring for each unit, rather than just focusing on surgeon and unit and mortality rates. It is a much better measure of quality, especially as mortality rates are now so low for most procedures. There's going to be greater focus on how each hospital performs rather than trying to focus on how each surgeon performs. We have a suite of online tools that allow hospitals to view their data in real time on the NICOR website, and there are 11 metrics that are now visible where you can compare your unit to how the UK is performing and how the best units are performing, so that you can do quarterly reports for your unit, or you can do it daily if you wish to, but you have to have timely upload of your data into the NICOR data set. And finally, the elephant in the room obviously is COVID. All this data is up until the end of March 2020, which was when COVID was only just beginning to take off. It's going to be interesting to see how the 2021 data compares now that COVID has had such a dramatic effect on our practices. Thank you very much. That's the end of my talk.